for the patient, because the patient believes that he removed the stone, now it's not going to come back. Or the patient believes that his colic is gone, the stone is gone, and that is the end of the story for the rest of his life. So you have to manage the expectations, and you have to tell them that this is something which is inborn, this is something which is likely to get. You have to take care of it. So let me introduce you to Mr. Ronit, who presented at 5 o'clock. This is the typical time when the patient would come to the emergency. And he presented with vomiting, pain in the right lower abdomen, surgical results, so I thought, appendix let's maybe get a chance. The first day will get a chance to do the surgery. He had diarrhea also, so that complicates things. So it's more likely to be appendicitis. Right lower abdomen pain, diarrhea. There's fever also. Oh my God, very good. So, but then there's mild backache in his back. I should say that I had such a pain. It was there in the back. It was not there in the lower abdomen. So it was a different kind of pain, but it did happen in his back also. There is no dysuria, there is no hematuria, and when you touch the abdomen, there is no cut, there is no tenderness, there is no rigidity. The patient doesn't say that there is a perineal pain, it hasn't migrated. What's the diagnosis? So with this kind of presentation, the vomiting has happened because probably the renal capsule has distended, it has, the pelvis has distended, and it has stimulated the celiac ganglion. That's why the patient has nausea. That's why he had a vomiting. So now what test would you like to order? Of course, there is something like a bazooka approach. Order everything. Hemogram, AFT, RF, everything has been done. And you saw the counts mildly raised, not too much. And the urine RF, of course, we're going to discuss those things. So that thing you already mentioned, you've already got it done. But what else? A USB whole abdomen. That doesn't. Or maybe you had a CT scan whole body. So again, we have to stop. We have to make the meeting here. What are the organs in the right eyelid side? So the ureter is there, the appendix is there, the cecum is there, the muscles are there, nodes are there, and of course vessels, arteries are there, all those kind of things are there. So we take that approach and then we make the diagnosis and we do order USP abdomen as well. Now basically the patient, at 7 a.m. now, and your sleep has kind of faded away. You've woken up with a cup of tea. Finally, although you were woken up at 5 a.m. also, but you have actually woken up. And the patient has come back to this picture on the ultrasound, which is a right hydroureteronephrosis. Now the radiologist was also in deep slumber, because he's also probably, we're just talking about his sitting here, and he's been seeing so many ultrasounds, he's been 200 ultrasounds in the previous night and the day together. And he couldn't take out the time to really figure out where exactly the hydroureteronephrosis was still, but he could say that there was some hydroureteronephrosis and the upper ureter was also dilated. There was some cecal thickening also. But then he just mentioned there were excessive bowel gases, so I can't say much. That's what I want to say. This is only the point till then when I can make an effort to make a diagnosis. But my friend, sorry, I've seen the canteen tonight, but up till then, this is all I can help you with. And the appendix you couldn't see also. So he's kept himself safe. There's no appendicitis because he couldn't see it. And when the bladder looks normal, but his urine RNA, it does show 10 to 12 RBCs. Now you read it in Bailey that appendicitis can also, sometimes show that when especially it's lying above the ureter. So you're still hoping, but no, sorry. So there are 1 to 2 first cells, and there are some epithelial cells which just tell that the patient was not given the instructions on how to collect the urine, and rather than saying that he didn't collect it properly, probably there was nobody to tell him how to collect. So what's the next test? You get an X-ray, you get a CT scan, a more expensive one, something which you will get to know by the next couple of days, and maybe till then the patient will be lost. Or you will repeat an ultrasound maybe with a senior, and maybe if you don't like that post-graduate and you want somebody else to pick it up. Anyways, further in the case, what we did, we gave a Dynapan injection. The patient has been nagging, the pain is there. You probably mentioned the CT scan, and you're awaiting further imaging to come. The pain has increased. Now, basically, I want to emphasize on what we could be giving this patient once you already given Dynapan or diclofenac. So the options that are there with us, they are one to repeat the NSAIDs, because NSAIDs you read were the drug of choice. They were the best thing that you could give to any particular colleague. Or you could put them on opioids, or maybe antispasm Olympics, or you could give progesterone. So these are some options. I'm not saying you have to just know the correct one, but these are all things that we do and we can give, and there's literature to support you. So we can give progesterone, we can use steroids, there's an acute colic to reduce the edema. Of course, we do give a lot of thyroxine, the buscopan. So, and then basically you gave it, the patient settled, and you said, okay, so now you come tomorrow, or whenever the CT scan is done, they come back to us in the OPD, and we'll see. Now, what medicines will you put on this discharge? This is a very important point, because usually the medicines I see when somebody has come is basically something like rotavirine with aciclovir, something which is a very good combination, very common, but nothing else is there. You know that there is a ureteric stone, probably it's down, it's not in the upper ureter because the upper ureter was dilated, so it's somewhere down, and this patient could be benefited with something called a medical expulsive therapy, MET. I hope you've heard this word, because if you haven't, you have to make a note of this word. It's called medical expulsive therapy. So we can give medicines to make the stone spontaneously go away, and we can also give them some inhibitors of stone formation, in the sense that if they're not immediately accurately, it will reduce the dysphagia, maybe symptomatically, maybe it will reduce the chances of formation of stone in the future. And it is not just for a week, those kind of things have to be given for some time. We will discuss today in this talk how long have to give. So medical expulsive therapy has to be given, a painkiller has to be given, a syrup has to be given, instructions to come back on certain symptoms like fever, bleeding, intractable pain. So these are things which we have to mention on discharge. Now just a word about medical expulsive therapy. So medical expulsive therapy has been tried for the small uterine stones. It's not that there's an 18 mm stone in the renal pelvis on the ultrasound and you write PAMS goes into this thing. He will probably have more postural hypotension or retrograde ejaculation, and he will bother you for that. He will not get any benefit maybe out for that 18 mm pelvis stone. So medical expulsive therapy is not something that you have to give to everybody so that nobody can point a finger at you. It's to be thought of carefully and then given to the patient. It is given for 2 to 4 weeks, and you can at least allow at least 2 weeks for this patient to take it and come back. It improves expulsion rates by up to 65%. Although I know my respected chairpersons will have reservations around it, but there are pros to it, there are cons to it. There have been so many literatures around it. My junior had a thesis around medical expulsive therapy, and it's still a matter of debate, but I would still say that it is something where you can defend yourself with scientific evidence, and there are results, so let's give it. Now it inhibits the basal tone of the ureter. So those muscles, the alpha-1 receptors which were there in the lower ureter, which were having a high density around the triangle, which were having a high density around the prostatic area, the bladder neck, all these are going to be relaxed by the alpha-1 blockers. So here basically, when you give the medical expulsive therapy, it's going to relax those muscles, and the stone is going to come down. It will reduce the intrauterine pressures, it will increase the fluid transport, so it might bring the stone down. The steroids can be added to reduce the edema and increase the rates further. So the typical favorite combination of urologists all across the globe when it comes to medical expulsive therapy is to give an alpha blocker with steroids. Now these are all possible things that you can give to the patient. They are all accepted. So you can give tamsulosin 0.4 mg, telling the patient about retrograde ejaculation and postural hypertension. You can give alpha-dosin to somebody who seems to be more sexually active, and then he would not be nagged further with retrograde ejaculation. This is the least chances of retrograde ejaculation, 0 dosin. This can be given, but again it causes 100% retrograde ejaculation. So the patient will call you up. Docs, I've given something, my semen is not coming out, and I don't want you to have that call. So just tell them beforehand. Deflazacort, this is a mild steroid, safely you can give. Especially if you have the hemogram, you can give it more confidently if there is no raise in TLC. Tadalafil, the phosphodiesterase 5 inhibitors. Typically that we give for patients with limpy penises who have erectile dysfunction. You can give it here as well. So there is scientific evidence to support you. You can give calcium channel blockers like amphetamine at a dose of 10 mg, or maybe an extended release of up to 20 mg. You can even give something magical called Procedural depot. It is progesterone. So it's given to those women who are not able to deliver their child. They want to relax the smooth muscles so that the baby can come out. So this is another delivery which is in the process. You can give this single shot deep iron, a depot preparation of progesterone. And then prednisone, of course, something that quacks have used for so long, but it does reduce edema and helps. So typically when I send off the patient on immunity and medicine, this is also something that I tell every patient. Because I don't know if the patient is going to come back again and will he be satisfied with the consult, will he be able to say that the doctor treated me holistically. So this is a typical diet chart. You will find it on the website also, but then basically we are working on increasing the fluid intake, making the specific gravity less than 1.010, 0.24 hour fluid correction, urine correction. So that's the goal. So we are trying to tell the patient that 3 liters of fluid is something that you can take. Don't take too much. It's just going to cause more pain or further no benefits of that exercise. Reduce the weight, reduce the salt, maintain your BP, sugar, reduce carbonated colas and calcium citrates, and then basically rest of the dietary approach is going to be based on what kind of stone is there. So we will come to that as well. But then we can always give calcium citrate. It works in most of the stones except for maybe the screw white stones, which are infected stones. Now back to the case. Now he went home. Now he has come to the other unit head's emergency, or worst case scenario. So he presented back to the emergency, another unit with severe colic, he had fever with chills. Here the TLC now is 14,000. And he didn't have relief, he was given all the same medicines, but he got no relief. And he was saying last time the doctor didn't see me well or something like that. And then his CPKVP had come. So it was a 7.8 mm stone, which was 900 Hounsfield unit. The Hounsfield unit is very important again, my friends, because it's going to help us decide what therapy can be given to this patient. If it's less Hounsfield unit, it means that the stone probably is something which we can break with extracorporeal shock or electricity. It's a stone which is not too hard. So it will be easy to operate upon it. Maybe if I just grab it with the forces, it's going to break into pieces. Now this stone is 6 centimeters from the pelvic ureter junction. So it's in the upper ureter. So curse your friend again. And then there is a perinephric stranding. So which means that there is some sort of a edema, inflammation that's going on around the kidney. The pressure has been sustainably increased. And that has been transmitted to the fat around the kidney. So there is stranding. Now what do you offer this patient? Maybe IV injections and a DJ stent. Maybe you offer a percutaneous nephrostomy, maybe a ureterovenoscopy, maybe a percutaneous ureteronephrolithotripsy. These are all options that we can offer to the patient because we find that he might be going into evolving pyelonephrosis, but this has to be confirmed with a baby ultrasound. Anyways, I'm just taking the story forward. Now, what if we do not do anything for this patient? If we don't admit him, he may have a complication of KVP, which again I want to emphasize to all the graduate, postgraduates here, that there could be impactable colic. So it may be so much that the patient can sometimes very rarely may even go to vasovagal shock. So somebody if you ask them what is the worst pain they have experienced in their life, it would either be labor pain or a bleeding, or it would be a stone or a dental. So that kind of colic is what we expect when a stone is stuck in the ureter. It could lead to infection in the parenchyma of the kidney, that's called pyelonephritis. It could lead to collection of pus in the pelvis called pyelonephrosis. There could be corneal rupture, as you can see in the CT. So we see fluid all around the kidney. So here the stone has caused so much increase in the pressure that there has been rupture from the pelvic elevation system and the urine has spread around. It's become a urine coma. There could be a urosepsis, there could be renal damage, of course. So we've tried tying the ureters of dogs, and up to 6 weeks we found that the kidneys are salvageable. If it's a stone beyond 6 weeks or an obstruction beyond 6 weeks, there is a significant renal impact. Now, how do we manage this stone surgically? So this is a complicated diagram, of course. Maybe I'll use the laser pointer to run through it. So if there is a small, so we have divided the kidney into the kidney and the upper ureter, the mid lower ureter and the bladder. So I just want to just make you run through all the processes, the procedures that we can do to help these patients who have kidney. So if it's a small stone, say about 7 to 8 mm stone, for example, in this patient, typically I would offer them medical management first because I want to save as many surgeries as I can. I already have so many to do. So you give surgical option in these patients only when the medicine is not working. If there is pain off and on, maybe the stone is coming down and going back into the kidney, the patient is tired of it, there is no relief with the medicine. The patient says, I'm a pilot, I have to join back. I'm a sailor and I have to join the merchant navy and they're not allowing me to join. You have to probably offer them surgical management because they can't wait that long. If the patient has recurrent UTI because of the stone and you're quite clear about it and there are other complications, then you can offer them lithotripsy, where we break the stone from outside. I'll show you quick videos around all these procedures. We can offer them retrograde intrarenal surgery, we can offer them mini percutaneous nephrolithotrips. Then if it's a medium stone, say about 8 to 20 mm, I can still offer them ESWL, specifically when I know the stone is a little light stone, it's going to break. So it's less than 1000 pounds per unit and the patient is not obese. So I want the distance to be less between the lithotripter, the spark plug generator and the stone. So it has to be less than 10 centimeters distance. I can offer them lithotripsy. I can still offer them RIRS, PCNL and PCNL. Now if it's a very big stone, say about more than 20 mm, I have to offer them something which can take that volume. So PCNL, percutaneous nephrolithotripsy, as you can see, is something that can deal with almost any volume of stones and that has almost reduced the reasons for doing a laparoscopic or open pyelolithotomy or an anatrophic nephrolithotomy with the advances that have taken place. So we've removed 5 centimeters, 5.5 centimeters stone in single sittings. This is possible with PCNL. Now if it was a stone which is in the mid-ureter, lower ureter, again 6 to 7 mm, I still want to put them on medical management unless there are these complications there. Or we could offer them URSL, so which means that we're going to go from down below into the ureter and then we're going to break the stone. We'll see the small video of that as well. And we can put them back into the kidney and then remove it from the kidney. We go in an anti-grade fashion and remove it. And then basically we can offer lithotripsy as well. If it's a bigger stone, again I can't probably I don't want to offer them lithotripsy the first twice. I would probably want to offer them URS with, or maybe if required a pushback PCL because it's still high up and there are chances when I go down with the scope with a lot of fluid there to show me the way, the stone may go back into the kidney because of the pressure of that irrigation. And so that's why I want to keep the pushback PCL as an option for the patient to take a consent at least on paper. Maybe I don't need it. And if it's a very large stone, again, then we have a role of a lab ureterothotomy. If it's a very, very large stone, and we think that being in the ureter for that long with the scope can injure the ureter constrictor or not. Now, coming down to the lower ureter again, as the stone comes down, the chances of the stone passing on its own, they increase. So I want to keep larger stones on medical management if they are down. At least offer them to the patient and call them back with the possibility saying that we may need surgery. And if it's larger, of course, we will offer URS whenever it's in the lower ureter. If it's in the bladder, then I can offer them cystolithotripsy. So I go through the urethra, put my scope up, break the stone, take it out if it's a small, less than 20 mm stone. If it's a larger stone, I make a hole in the lower abdomen, like a PCNL that I will show you, and do a PCCLT for a large stone. If it's very, very big, I may want to, offer an open surgery as well. So this is ESWL. Here what we'll do is a balloon attached to the patient. There is a spark plug here. It's going to generate some waves. And there are various generators that are available. We give about 3000 shock waves to the patient for an hour's time. He's lying on a table. There is absolutely very little pain, very bearable. Usually we don't need anesthesia, just simple monitoring is enough. And we give weekly sittings, so about 4 to 5 sittings. We call the patient every week. We see his X-ray if the stone has broken. And then we again subject him to the next sitting. But it can cause some complications which are again, you can say, apart from renal trauma, most of them are still under dispute. If pancreatitis, hypertension, they are clinically significant and they would want us not to offer ESWL. ESWL is something which is there for the last 30 years. It has gone out of the picture because technology has come in, but it is coming back. Now, more and more people are recommending lithotripsy back again. So this is something that if you had a stone, you would want to probably go ahead with something ESWL. Let's quickly see how it's done. So this is the lithotripter. I will just quickly make you run through the videos. So this is the lithotripter. You can hear the sound of the lithotripter. So it's making those sounds. The patient is lying comfortably. This is the lithotripter, and there's this part like I will show you. This is the balloon basically is making. There's a spark here. It's generating those waves going onto the stone, and they are being seen through active CR monitoring in the fluoroscope. So this is how the procedure is done. I just want you to have a practical hands-on look at it. Then we have URSL that we talked about, which we offer to this gentleman friend of ours on it. Now here we have very, very fine scopes, say about 4.5 French onwards, up to say about 8 French. And we put them through the penis or the urethra. Eventually we go into the ureter and there we find the stone, we break it and then we remove those pieces. But this is a rigid thing, it's a steel thing. And if you're not gentle enough with the R structure of the urinary system, you can perforate, stricture, you can make the stone migrate into the submucosa, and you can even have UTI when you're using a lot of pressure while dealing with this. So let's quickly have a look at the video of how we do a URS. So basically here we are inside, we have the URS with us, and basically we are inside, we are seeing the image, we are inside the. So we first what we do is we put in a guide wire, we make sure that we do not enter anywhere else. So this is a safety guide wire which we have placed. And then we go in and we basically, this is a laser, so we're going to break the stone with the laser. You can see the stone here in the ureteric lumen. And we're going to break it and we're going to remove the pieces with the forceps, and that's about it. Usually it takes about 5 to 10 minutes depending on how big the stone is. This is the forceps that I'm introducing through the ureteroscope, and basically we're going to take the entire thing out, and that's about ureteroscope. Let's move further to RIRS. RIRS is one of the latest that we offer as urologists. We are very keen and proud to be doing it because this is a 5 or 6 lakh endoscope. It's going to move anywhere, wherever you want to take it inside the kidneys for a ride. And basically, whether it's an ectopic kidney, it's an anomalous kidney, the multiple stones, you can just take it anywhere. It's not limited by the anatomy, the locations, and it's a technically demanding process. Let's quickly go through how we do this. So we introduce an access sheet, and then basically we introduce this. So you can see the scope can move anywhere. We can bend it 270 degrees here and there. This is a basket that we have, through which we can hold the stone, bring it down. So that's the beauty of this. It looks like a sci-fi thing from the movies. And basically, let's move ahead to PCNL. So PCNL again, it initially started with about 34 French, way back about 20 years from now, and sirs have been doing it since that long. I've seen through them only the process for the first time in my life when I was in my undergraduate. And basically now we have miniaturized the scope. We've made it smaller and smaller to the point that we have made it as big as a ureteroscope now. This is called micro PCNL, but you just need to know ultra, mini, and micro PCNL, and there are a lot of complications with this process. You will find it all in the surgery update handbook. And you can enjoy all the systems because they're going blank. So I just want to quickly make you understand how PCNL is done. So first what we want to do is PCNL. We're going to basically cannulate the ureter, and we're going to enter the pelvic elevation system. And after that we're going to basically put in a UCAT, a ureteric catheter. We put in a Foley's, and then what we do is we make a puncture. So you can see that I have made a puncture from the back. So the patient there is lying prone on his side on his stomach, and I have made a puncture with the stone. And then you will see that once the puncture has been made, I will find that urine is coming out. The urine is coming out, so I dilate the system, and then basically I go in. I'm sorry for taking a little extra time. So we break the stone inside. We have to dilate the system first. Let me take it to gastro. And here I have my nephroscope going in, and I'm going to break the stone and I'm going to take the piece out. So this is PCNL. So in this case, we did a URS with stenting. We discharged the patient. But is the treatment over? So we still need to do a stone analysis for this patient, and then we go on to the specific management. We have to see what the stone has been made up of, what is the chemistry of it. Then we do a few serum tests, we do a urine chemistry test, and we offer medical therapy. So patients where we have the first time stone former, we usually do not straight away offer metabolic evaluation. Although many studies say that we should. But if it's a recurrent stone former, we definitely want to go for a lot of tests around the urine, which again are there in the update. You have to check for the total 24-hour calcium, cysteine, xanthine, if that's been taken by the patient, and the volume, the creatinine, all those things we have to see the oxalate content. And based on that, we can figure out whether the patient has been excreting a lot of calcium because his intestines are absorbing a lot of calcium, or maybe the bones, they are being degraded by a high PTH, parathyroid hormone, is it degrading the bones and letting it pass through the urine, and or if there is uric acid being excreted excessively. All these kind of tests we can do, and then we can ask the patient to take those specific measures to prevent the recurrence of stones. So these are the various stones that we commonly find: calcium stones, fluoride, uric acid, cysteine, xanthine, silica. All these are the common stones, and here are some of the tests that we typically do in these patients so that we can prevent and again holistically treat the patient. Thank you so much, and apologies for exceeding the time, and over to my respected teachers for